welcome everyone to Dean Dorton's overview of the 2021 EM coding changes brought to you by Dean Dorton Healthcare Solutions. Just want to let everyone know that we will be recording this webinar and we will be distributing the materials afterwards. We would like to direct everyone's attention to the bottom of the screen for the chat function. If you have any questions, we will be monitoring the chat feature at all times throughout the webinar. So please press the chat button and you will be able to chat the host and chat the panelists, and we will make sure that all of your questions get addressed. If you ask something that we don't have an answer to right away, we will make sure we get those answers to you as soon as possible. With that being said, I would like to introduce Adam Shoemaker to introduce everyone to Dean Dorton Healthcare Solutions. Thank you so much, Adam.
Thank you, Julia. Appreciate that. As Julia mentioned, my name is Adam Shoemaker. I am the Director of Healthcare Consulting Services here at Dean Dorton, and welcome to today's webinar. I think it's a timely presentation and one that many people are very much interested in. For those of you that are unfamiliar with Dean Dorton, we provide accounting, advisory, and outsourced services to healthcare organizations, including numerous physician practices across the country. We think it's important to address and discuss key regulatory changes when they are set to occur, and this is obviously one of those. These changes can have an impact on your internal processes as well as cash flow and potential compliance risk. And facilitating today's presentation will be Brandy Montgomery and Danielle Langdon, members from our firm's Coding Compliance Services team. Brandy and Danielle are both certified professional coders as well as certified professional medical auditors. Their team provides medical coding and documentation audits to help clients manage risk and ensure appropriate reimbursement. Brandy, I will hand the baton to you.
The background for the EM changes. In 2017, the CMS administrator, Seema Verma, launched the Patients Over Paperwork initiative in accord with President Trump's executive order that directed federal agencies to cut red tape. In response, in 2018, CMS proposed revisions to those rules that went into effect on January 1st of 2019. Those changes were as follows. For an outpatient visit with an established patient, the provider can record what has changed since the last visit. There's no need to re-record the history and exam if there's documentation in the note that the provider reviewed and updated that info. And for an outpatient visit with a new or established patient, the provider doesn't need to redocument a chief complaint or the history that was recorded in the medical record by staff or the patient. This includes the chief complaint and any other part of the history, the HPI, the PFSH, and the ROS, the review system. But the billing provider can review the information and update it as necessary, and also document that that information was entered by the staff or by the patient, and that he or she reviewed that information. So on January 1st, 2021, more extensive changes are set to go into effect. Extensive E&M guideline additions, revisions, and restructuring, which we're going to go through today. The deletion of code 99201 and 99202 through 99215 are set to be revised. So now code level selection should be based on medical decision making or the total time on the date of the encounter. There's a creation of a 15-minute prolonged service code to be reported only when the visit is based on time and after the total time of the highest level service, 99205 or 99215 with level 5, once that time limit has exceeded the total time. That code is 99417. And although the history and physical exam elements, those are recorded, they will no longer factor into the level of service selection. So with the CPT changes, the American Medical Association, they created new descriptions for the office or other outpatient services. This is for both new and established patients. They can be based upon the level of medical decision-making or the time spent on the encounter. So notice that we're saying on the encounter date, not just face-to-face. We'll go into that in a little bit. For each code descriptor for these services, all references to level of, like the history and the exam, they have been removed. So now it's specified that there must be a medically appropriate history and or physical exam and a specified level of medical decision-making. So again, history and physical exam, those are taken out of the equation to determine the level. Now it's pretty much based on MDM. Now if you want to bill by time, the length of time corresponding to each level of visit is specified, and we have a table of those towards the end. Current time rules for coding apply when counseling and or coordination of care dominates, which is more than 50% of the encounter, and includes only face-to-face time in the office. That's what's current. In 2021, the providers who want to code by time spent, that can include all related activities on the day of the encounter. So it shows all the work involved in your patient's care, not just what you do in the room with the patient. So we're going to move on to the medical decision-making selection of the level coming in 2021. So for the number and complexity of the problems addressed, the greater the number and complexity addressed, the higher the applicable level of decision-making. And of course, we know that there are 4 of those levels: straightforward, low, moderate, and high. Several specific problem level options are listed. We'll show those in a little bit in another table. Those range from self-limited or minor problems to acute or your chronic illness or injury that poses a threat to life or bodily function. And the amount and complexity of data reviewed and analyzed. So data is divided into 3 categories now. So category 1, those will be tests, documents, orders, review of prior external notes from each unique source or historian. Each test, order, or document is counted to meet a threshold number. Category 2, that's independent interpretation of tests that are not reported separately. Category 3, that will be the discussion of management or test interpretation with external physician or provider, not reported separately. The risk of complications and or morbidity or mortality, that's the assessment of the relative danger of patient management, whether from treatment or further workup. And those levels, it's minimal, low, moderate, and high. Some treatments are relatively risk-free, as we know, over-the-counter medicines, dressing changes, and some are highly risky. So that could be your decision about emergency major surgery. And all this will be cleared up a bit as we move forward in the presentation. And as we'll go along, you should realize that the potential benefits of these revisions, you'll have more time to spend with your patient because you'll have a lighter documentation burden. Once again, I want to point out that the history and exam, those elements for code selection, those are eliminated. So they no longer determine the level. Of course, you have to document those, and they must be appropriate, but it doesn't determine the level. There's recognition of work involved in non-face-to-face services like care coordination. So that's where your time comes in. If you're going to code based on time, that it takes into account everything that went into taking care of your patient, not just while you're in the room with your patient. And the focus is on patient care management instead of simply adding up the tasks. We know how that is. You don't have to just try to get those work points in. You can focus in on taking care of your patients, which is what we all want to see happen. Now let Danielle go ahead and start this part about the E&M codes.
Good afternoon, everyone. This is Danielle. First, we're going to start off by talking about the new versus established patient. In 2021, we are not going to see any changes to this. It will still be the same 3-year rule that has applied in the previous years. For example, a new patient is one that has not received any professional services within the past 3 years. And you also have your established patient who has received services in the past 3 years. And again, we have those same guidelines referring to physicians within the same specialty. So that will be the same. We won't see any changes to that at all. We really start to see the changes within the levels. So as previously discussed, we know that the history and the exam will not be used in leveling these new encounters. They would still like to see a relevant and appropriate history and exam. Same as before, the history can be documented by, parts of the history can be documented by ancillary staff and reviewed by the provider. And again, the levels will focus more on medical decision-making and time as defined in the next slides. So again, we're going to be following 2 new rules, which is leveling with the medical decision-making portion of the encounter, or we are allowed to use the total time for the encounter performed on that data service. Medical decision-making refers to the complexity of establishing a diagnosis. These you will see are very, very similar to the previous guidelines, but there are some key differences. We still have the number of diagnoses, but we also want to include the management options as well. In the other category, we have the amount and complexity of data to be reviewed. This includes diagnostic tests, same as before, medical records, and other data. And then we see some differences in the risk of significant complications in that last category. We're more focused on patient outcomes. We're looking at morbidity, mortality, anything included with the patient presenting problem, diagnostic procedures, and possible management options. For each encounter, as in previous years, we still want to see an assessment, a clinical impression, or a diagnosis. We want to make sure that those are still documented clearly within these records. For presenting problems with an established diagnosis, kind of the same as in previous years as well, we want to know whether those addressed problems are improved and controlled, or we want to know if they are inadequately controlled or worsening, because that will affect your medical decision making as well. A little more detail on what is involved in the medical decision making. With the weight of your E&M level moving over to the medical decision making, documentation on what you perform for that patient on that data service is more vital. We want to be able to see documentation of diagnostic tests. If you've reviewed those tests, initialing the dates, documentation that you've decided to obtain old records. We also want relevant findings with a notation of old records reviewed, kind of as previously will not be sufficient. The discussion of lab, radiology, and other diagnostic tests with another physician who performed them must also be documented because that is, again, part of the medical decision-making criteria for the changes. And also documentation of direct visualization and independent interpretation should also be documented. So we want to make sure that we get a good idea of everything you did for that patient on that data service. And again, this is kind of the same as previous years also. We have the levels of medical decision-making, which I think we're all familiar with. We still have straightforward, low complexity, moderate complexity, and high complexity.
And as I said, we have the table for your time-based, if you're going to decide to bill based on time, for new patients. And this is including non-face-to-face, so it's the total time spent on the date of the encounter. For level 2, it's 15 to 29 minutes. For level 3, it's 30 to 44. Level 4, it's 45 to 59. And level 5, it's 60 to 74. And again, with that level 5, if you go over that time threshold, it's for 15 minutes, it'll be the new code 99417. So that is the 15 minutes of prolonged care done on the same day. For established patients, your 1, 2 through 1, 5, it's 10 to 19 minutes for level 2, 20 to 29 minutes for level 3, 30 to 39 minutes for level 4, and 40 to 54 minutes for level 5. Again, the 99417 will apply to both new and established patient time.
In the next slide, we have the table of medical decision-making. At first glance, it does look very similar to the previous tables that we used for our medical decision-making, but there are some key differences. This table can be found on the AMA website, which I think we have linked at the end of the slideshow, so feel free to look it up. There is also a link to the definitions used by the AMA to further explain some of the changes on the MDM table. So you'll notice right off the bat that the level 1 is no longer available for use. We have our level 2, which is 99202 and 99212. They are considered straightforward with minimal or none risk associated. And then we move to our level 3, our 99203 and our 99213, which are low. In the number and complexity column, we have 2 or more self-limited or minor problems, which I think most of us are familiar with in previous guidelines. We also have 1 stable chronic illness and 1 acute uncomplicated illness. Again, there have been slight changes to the definitions of some of these terms that help us give us more detail on what we can consider chronic illness and acute uncomplicated illness. And again, those are listed on AMA's website and are really helpful to review. The middle column, the amount and complexity of data to be reviewed, there are some big changes within this category. You'll notice that you must meet at least one of the 2 categories. Category 1 is listed as tests and documents. Category 2 is assessment requiring independent historians. Within Category 1, you have to meet a combination of 2 of the following listed. So prior notes from each unique source and a review of results from each unique test and ordering of each unique test. And this is language different than we had previously seen. So the providers will be getting credit for each test reviewed and each test ordered, and instead of it being lumped under 1. Then moving forward to the risk of complications and morbidity or mortality. Again, they redefined this column slightly so that we are looking more at the risk to the patient, what the management is going to look like for the patient moving forward. And then moving on to the 99204 and the 99214, we're looking at more complex cases with our number of complexity and problems addressed. We have one or more chronic illnesses, two or more stable chronic illnesses, one acute with symptomatic symptoms, and one acute complicated. So still very similar to what we have seen previously. And then the amount and complexity of data to be reviewed, we see that expanded with a third category. The third category is discussion and management or test interpretation. So you have another category addressed in these higher complexity visits. So with this one, you have to meet at least one of the three categories. And then with our risk of complication and morbidity or mortality of patient management, we see the very familiar prescription drug management, decisions regarding surgery. So that's very similar with just a couple of changes in the language to make it easier for us to understand. And then our last level, the level 5, 99205 and 99215, again, very similar. We have the number and complexity of problems addressed. We've got our one or more chronic illnesses with severe exacerbation, and our one acute or chronic illness or injury that poses threat to life or bodily function. So again, that we're pretty familiar with that. In the amount and complexity of data column, we still have the categories 1, 2, and 3. The difference with the level 5 is that you must meet 2 of the 3 categories in order to fall in the extensive range. And then the risk of complications, our last column, is again very familiar to what we've seen before. We have examples of drug therapy and monitoring for toxicity, elective major surgery with identified risks. So very familiar terminology that we've seen before with just a few different definitions to get more detail of what is all involved in that. So here we have an example for you guys so you can kind of see how the 2021 changes are going to affect your encounter. And I do want to start off by saying that this example is not an example of how your documentation should look. We just wanted to get something on the screen for us to look at and see how the level will be different with the 2021 changes. So for this encounter example, we have a chief complaint of a patient coming in for a follow-up visit due to osteoarthritis pain. Our HBI is going to be leveled at a status of one chronic condition. So just a quick review, the patient was recently diagnosed. She's feeling good after new medication, reports a little bit of stiffness in the morning. So just a quick HBI. We noted that there was no review of systems obtained and there was no personal, family, or social history obtained. We have a quick exam with our vitals, general appearance, respiratory effort was documented, heart sounds were documented, and the patient's gait was noted. In the medical decision-making, the provider had documented that they reviewed did an independent review of previous blood work from a different provider. They ordered additional labs to check the meds. They might have ordered an x-ray, and then, of course, we have the prescription drug management for the new medication started. So in this example, if we use previous guidelines and were to code this in 2020, this would have leveled at a 99213. We have a history of expanded problem focus. The exam was an expanded problem focus, and the medical decision-making was moderate. So because of the 95-97 guidelines, we had to consider 2 out of the 3. So this would have actually leveled as expanded problem focus with a 99213. Now with the new guidelines starting in 2021, this would actually level at a 4. So we would have a 99214. Because the history and exam, while they're medically appropriate, they're not counted in the level of the visit. So because the weight of this encounter was in the medical decision-making with a moderate level, this would actually be a level 4. So there are a lot of benefits to the new leveling of these exams. And now back to Brandy.
So just a couple of reminders that I always feel is necessary to review quickly with any audience. It's about the documentation itself. As we all know, Medicare can review beneficiaries' medical records. The proper documentation, that'll address any challenges raised about the integrity of your claim. And we've all heard it. If you didn't document it, it's the same as if you didn't do it. I'm sure that everybody's a little tired of hearing that, but it's a good reminder. Just document everything that you do. And, of course, medical necessity. It is the overarching criterion in addition to the requirements of the CPT code. That means that the services that the physician determined are required to address a patient's medical condition, the services that meet the standard of care for that patient's medical condition, that the care is clinically appropriate and it's considered effective for the illness, injury, or disease, and it won't cost any more than any alternative service that is at least as likely to produce equivalent therapeutic or diagnostic results. Here is a list of our resources that will be made available to you. And now I guess I will turn it over to questions.
So, Brandy and Danielle, thank you so much for that. We actually do have a couple questions from the chat feature, and we are monitoring that. So please send any questions you have our way, and we'll make sure those get answered. But first and foremost, the question we have at hand is, if you use the 99417 for prolonged, do we need a modifier?
Oh, that is a good question. Let me double check this. I do not see that it's documented in any of our references to build that with a modifier, since it is its own definition in addition to the prolonged care, so no.
Okay, we actually did just get another 99417 question, so bear with me. 99417 is applicable to all levels of service or only when going above total time for level 5?
It is only to be used in addition to if you do a level 5. So for a new patient, for the 99205, if you spend less than 75 minutes, you will not report the 99417. For level 5 established, 99215, if you spend less than 55 minutes, it will not be reported.
The last one we have for right now is, if you order and review a test, can you count both ordered and reviewed?
Order and reviewed of that test?
It just says if you order and review a test, can you count both ordered and reviewed?
Danielle, correct me if I'm wrong. I believe that is still I believe it's still one or the other. Is that correct, Danielle?
Yes, I believe so, and I think that might fall into that separately reportable category as well. You got to be careful that it's you're not also billing the lab itself in addition to counting that towards your E&M, correct? Like not separately reportable?
Right. Yes.
Okay.
Hope that answers. And one more thing about that 99417. So if you spend 90 to 104 minutes with a new patient, 99205, that would be your level 99205, and then 99417 times 2. Just so that's clear with everybody.
We just got another question. We were using the 99211 for the nurse visit. Will that no longer be possible?
Danielle?
So I think that the work that goes into the 99211, they have moved that into the level 2 category. Again, you just want to make sure that you have a billable E&M service documented with the proper documentation in order to bill that out.
If I order a PFT and then read it and then review with the patient, this only will count as one for MDM reporting, correct?
Yes. And that'll fall under those categories.
Okay. Great. We just got another one. If the provider orders an X-ray and reads the X-ray, it does not count in the MDM because we can bill globally for the X-ray?
So I think that might be one of the ones that fall into the separately reportable, because if you're billing the global X-ray charge, you're billing for the technical component, and you're also billing for the reading component, which is included in the global charge for an X-ray. Does that make sense, Brandy?
Yes, that did.
If you review records prior to the visit appointment, can that time be added to the visit?
As far as we know right now, this is going to be on the date of the service, so it doesn't have to be face-to-face, but if you review it prior to the patient coming in that day, yes.
Does the 99417 have an allowable/payable amount that you've seen yet?
Not yet, but I will make a note. So here we go. This is how you can contact me and Danielle.
And thank you so much for attending.
Thank you all so much for your time. Have a great day.
Thank you.
Thank you.
Bye-bye.